to the topic. I'm more of a facilitator. I'm not going to be like a speaker really. So just kind of give a little more information into some of the background before our panelists start talking. So this is our perfect. Okay. Oops. There we go. So, brief note, because we're going to have a few different people talking. We do have panelists here tonight that have affiliations to different organizations, but the views of the panelists do not necessarily reflect the views of those organizations. They are speaking primarily for themselves and on behalf of their own experiences, not necessarily on behalf of any organization. And before we move forward, I was just if the panelists would like to just give name, title, very brief like role, and then later on I'll kind of probe you a little bit deeper about the different things that y'all have done. Um, Eduardo, you can go ahead. I see you're unmuted.
Sure. Yeah, my name is Eduardo Juarez. I am I'm on the board of the Bear Area Harm Reduction Coalition, and I'm also an attorney. Um, so I think that's enough. Yeah.
Yeah, cool. Thank you. And then Dr. Dasho.
Hi, everyone. Thank you for hosting this, and Nima, thank you for putting it together. Yeah, my name is Matt Dasho. I'm a physician, internal medicine specialist, primary care and hospital medicine. I direct the Cheever Center for Medical Humanities and Ethics here at UT San Antonio's Long School of Medicine, and we encompass all things arts, humanities, ethics, and global and community engagement. Our street outreach initiatives have sort of found, at least as far as the student engagement, have found a home in the Cheever Center. I'll popcorn it to Nandini.
Hi, everyone. I'm Nandini Mandlik. I'm a pediatrician, outpatient, and also director of operations and interprofessional education for our free clinic program, which is formerly known as the Student Faculty Collaborative Practice. Um, my background and interest is really in care of the underserved. I worked at a community health center for many years and do some migrant and refugee advocacy work. Um, and my role with this is really to facilitate the operations and um, getting the student involvement solidified and kind of built into the structure of the free clinic program, along with Dr. Dasho's work at the institution, kind of partnering and supporting that effort.
Uh, Thank you. And then Susan, also, I know you're here if you want to introduce yourself.
I'm Susan Yerkes. With Eduardo, I'm on the board of Bear Area Harm Reduction Coalition, and I'm just excited to hear you all.
Cool. First, a little brief background on something that we have, and panelists, please interrupt me at any time. We have these things at our school called Community Engaged Learning Grants. They're through the Center for Medical Humanities and Ethics. It's an interprofessional program at UT Health. It involves both projects that basically have both a community impact and a scholarship component. You can apply for these grants up to 4,000 per project per, I guess, really every half year that the cycle comes up. And it's kind of like one of the sort of famous things that we do at our school. People come up with really cool ideas, and actually some of our student-run free clinics have started this way. I want to say most of them probably, all of them, I don't know. But definitely has had a huge impact on the kind of work that we can do. And the reason why I bring this up is because the project that I started working with also started as one of these. So it was like a little bit of funding we got, and we're able to kind of grow it with the help of our panelists. So the project that we do specifically is wound care outreach at Bear Area Harm Reduction Coalition. It was started in 2003 in the city of San Antonio by a blood banker with lived experience. He was interested in reducing HIV and Hep C, which he felt like were not being adequately addressed at the time here in the state. And what's really incredible about it is actually Bexar County's first legal syringe exchange. Members who were involved, now the organization itself did not, but members who were involved in the organization were actually part of the big push to change the law in Texas to establish a pilot program in Bexar County, which eventually happened in 2006. And then it took another like 12 years before the district attorney actually wrote a legal opinion saying that it was legal after the legislature had changed the law. It only remains legal in Bexar County and nowhere else in Texas. And specifically, we set up in the heart of the opioid epidemic within San Antonio. If you look at a map of overdoses, you'll see this giant hotspot in a certain area. And we kind of set up there, handing out, of course, doing syringe exchange, but then also like big things like naloxone, other harm reduction supplies. But of course, we are not really the first organization in San Antonio to be doing anything like this. Street Medicine San Antonio has been around since I want to say like 2019 or 2018. There is also UT Health SA Street Nursing. They've been around for a while as well. They've been going out to certain sites in conjunction with Corazon Ministries, which is a sort of day center in town that gets people resources. It has a food kitchen. It has a clinic component as well to it. And then more recently, Be Well Texas, which is an organization that operates as a part of UT Health. They do a lot of they get a lot of grants for different projects in the community involving partially supporting some of the stuff that our student-run free clinics do, at least at Alpha Home, I know. And then there's also the Street Medicine Interest Group, which is just a student interest group run by medical students as in addition to the Street Nursing Interest Group. So where we've kind of gotten to today, and we'll talk a bit about how we got here, we've got nursing students and medical students collaborating together. We've gone out a few times together. We're trying to expand all the schools at UT Health that come out with us to do our wound care outreach at BARC and also now at Corazon. We're working on a SOP. We just had our inaugural year of street health liaisons, which are working with coordinators of our other student-run free clinics. And our current outreach sites include BARC every Saturday and then Corazon Ministries when we're able to align the schedules. And then Dr. Manlick, I think this is your slide, so I'll let you expand on that more with this.
Oh, yeah, thank you. I think what Nima just described, just trying to kind of lay it out in this way, the initiative really, and to put context on that community engaged learning grant program he discussed, each of the clinics really did start with student initiative and push, and then because of the grant funding, being able to conduct a project with their chosen population, legitimized it and really got the ball rolling for leadership. So in the same way, in this case, the services that are being provided are we're trying to be in collaboration with these organizations that already have been providing services and using the students as kind of a connector with these organizations and then, providing a workforce for what their needs are. But then with the clinic's intention primarily being education, wanting to bring in multiple professions under the umbrella. And so trying to connect the nursing interest group and the medical student interest group, and then the social workers who already work with these organizations, helping them all, learn skills from each other and collaborate, which would impact, the health that's provided, the care that's provided, but then also like hopefully their future professions and professional interest. The structure of the free clinic program is such that we have 6 clinics that operate with different community partners in different locations in the city. Each of the clinics has student leaders who are effectively like our clinic managers and do that role for a calendar year. It's like a January to December. So when this street health effort came to be, we wanted to kind of tuck that into the free clinic program, and created these student liaison positions so that medical and nursing can be represented within our our umbrella program for the free clinics as a whole. That's what I got.
And then this timeline, I know Dr. Dasha, you'd put some of this together if you wanted to share kind of a story about how we got here and the timeline and all that.
Yeah, I think I won't like bore people with an entire, march through our, our year and a half or so of work. But I think the bottom line here is that, what we try to do in our center is to sort of capture the energy and passion of our students and make sure that what they're doing is aligned with the needs of community partners and the work that those community partners are doing. And so, a lot of the work and that goes into putting the program together. And I would say, judging based on, I think, the affiliations of this student group, many of you are coming from very mature street medicine programs. We're very new, and so we're sort of putting the boat together as we've already sailed out to sea, so to speak. So, but the key is that we are driven by the needs and the articulated and stated goals of our community partners in a way that helps engender compassion and joy of service. So what we've tried to do is respond to both changing needs in the community as well as changing sort of climates that we're all, I think, navigating in terms of the care of this population. And so we've managed to secure, small little pieces of funding from different agencies and organizations that see this as an important, area of education, especially to help our, learners understand non-medical drivers of health, such as housing, such as poverty, such as lack of access to healthcare or education. And so, so what you can see is that from the timeline, we sort of started with a lot of student interest and basically have sort of put guardrails around it to make sure that what we are doing, aligns with our institutions' kind of guideposts as to how we do community engagement, but then also making sure that the students are responding to and the other trainees are integrating into work and strengthening work that's already happening in the community, and with an eye towards, obviously, towards sustainability, which thus far we're not quite there. Some programs, I know some of the organizers here are from California or from Pittsburgh, where there's very mature programs. We're still on that journey towards sustainable funding. So I put Spring 2026 as it's a very lofty goal, but it's going to take some time.
Oh, and then this about
Yeah,
the
and I'll just kind of continue on this, that like, as I said, we work with various partners. I would say partners that are on campus and that are in the community. So we're very blessed, I think, to have wonderful partners like the Bay Area Harm Reduction Council, like Corazon Ministries, like Street Medicine San Antonio, who are kind of covering the gamut of clinical care, of education, and then of administration and management. We've managed through these on-campus and community partnerships, started to build, I think, what is a pretty strong coalition. As most of a lot of street outreach programs are there's 100 of them happening at any given moment, and it's hard to coordinate. And so on our end, what we've been trying to do is just make sure that when we're advancing a program, especially when it's involving trainees, that we're being very cautious and careful to make sure that it's appropriately aligned and integrated with the needs of our partners. So that's all I'll really say about that. But it takes a village. We do have funding that's coming from different areas. We have subaward coming from that's actually passed through funds through Bexar County, through federal funds that were designed for emergency response through ARPA. That is supporting some of the operations and clinical care for the individuals that we're caring for experiencing homelessness. We secured a grant from the Texas Higher Education Coordinating Board to help our residents learn more about and respond to addiction medicine and substance abuse, especially among the types of populations that we find experiencing homelessness. And then our center, we are able to sort of mobilize donor funding and things like that through, like Nima mentioned, the CEL program where students can apply for awards alongside community partners. And so wound care for being able to offer the volunteer faculty adjunct appointments so they can access the medical record, things like that. Those are all services that the university is providing to these community partnerships. Yeah, and Coalition of the Willing, tons of people on the team, and there's probably people that I didn't even put on this, but it's just to show that I'm sure, as many of you have experienced in your work putting these programs together, the amount of hands, the amount of expertise that I think that is required is pretty immense. And so this doesn't even make any mention of our amazing student leaders. This is all just on the institutional and programmatic side. But we have half a dozen or more student leaders that are also deep into helping us put this program together.
And some things I'll say, and part of why I wanted to do this is, I've worked with or talked to a lot of students in SMISC that talk about certain challenges with setting these programs up. And I will say one thing that many of y'all have probably heard me talk about is how I feel like our administration, at least at our school, has actually been great in terms of, being responsive. And I mean, as you could hear from the speakers, I really feel and I appreciate the fact that, everyone on the panel really, I feel like, gave their best shot at making this happen as quickly as possible. Of course, things don't happen overnight. And I've also just learned a lot of lessons throughout the way that I'm hoping to share with these with other students here. Definitely a lot of different things to think about. And I'm going to kind of skip through this because we'll definitely talk about it in the discussion. There's definitely some important points that I'll make sure to touch on, especially with some of the legal stuff, and Eduardo can also speak to that a little bit. So we can go ahead and move to the discussion portion, and people are free to ask questions. I do have a list of sort of discussion points to make sure that we discuss throughout this time, but as we're going through, if students have questions and want to just kind of unmute and share, please feel free to do so. We already kind of talked about each panelist's position. I do want to ask for each panelist if they could just share a little bit about their background, more broadly, even before their current position, involvement in similar efforts at other school, maybe not street medicine necessarily, but just establishing new partners and new ways of outreach. And then also your involvement in what's been currently going on with street health.
Eduardo, you want to kick it off?
Sure. So I'm born and raised in San Antonio on the west side, actually, maybe about 10 blocks away from our site where we have the needle exchange every Saturday. I went to Central Catholic High School here. I went to Notre Dame for college. Then I went to University of Michigan Law School, spent time in a big law firm in Chicago, was a public defender in DC. Probably that's the equivalent of street law, for 10 years in DC. And then I moved back to San Antonio where I worked at the EEOC doing federal civil rights, employment civil rights litigation for 21 years. And then I retired, and I've also been a member of Alcoholics Anonymous, been in recovery for 30 years. And so one of the individuals who was instrumental in kind of getting BARC to exist was a good friend of mine. And so I started getting involved with the Bay Area Harm Reduction Coalition. And so I've been involved and became a board member maybe for about 2 years. I can't say that I have, other than BARC, I don't have any other experience with regard to harm reduction or street medicine, or but I've learned And I've enjoyed, my volunteer work with Bark.
Well, I'll just say that, I mean, I'm somewhat intimidated by the panel and by the attendees here, because many of you are coming from very, as I said, very mature programs. My background is global health. I've been in global health practice and education for most of my career, working in low resource settings here in the United States and in other countries. And so I'm a newcomer to street health and to street medicine. But as many know who have maybe done international rotations, there's ways of thinking and there's ways of understanding problems, and problem solving that you can derive when you work in low resource settings that you can then apply, no matter where you are, whether you're in a high income country or a low middle income country. And so I feel like global health work and work with, with populations of low socioeconomic status, in the United States and around the world has prepared me, for doing street medicine. I'd say it has been a huge learning curve, and I've been very humbled by the social workers, the nurses, the physicians, PAs, the folks that are out doing street rounds, the nonprofits that have committed themselves to these missions that open their doors, that keep people warm when it's cold outside. This is true service, and it's very inspiring. And I think it's the kind of thing that, for me, it's extremely important for our students. Especially in times that sometimes feel cynical or difficult. And I'm talking over decades now. To be able to connect with that spirit of service, and try to make lives better, for people in our community, especially those in need. I think those are extremely important. So I would say there's background that I bring in my past related work, but I've really, really been more of a learner over the last year and a half. And the only thing I've really been able to, I think, contribute has been sort of bringing all of the pieces together and trying to, make sure there's money to do it. Off to you, Nandini.
I appreciate everything that Dr. Dasho just said because I feel the same way. I mean, certainly as a pediatrician, it is clinically outside of my wheelhouse. Street health work in my area is really more related to the unhoused and impacts of poverty on children and child development. So it's very different. I think really, so prior to coming to academics, about 10 years ago, I was working at a community health center, rural health center outside of San Antonio, and was medical director there. So I really started there to understand about how funding works, and how, nonprofits and partner agencies can come together to provide service, to the community without a ton of money, without a ton of resources, but a lot of motivated people, and also how to um, better partner with community agencies, leaning on them to, do the amazing things that, like, for instance, that Dr. Dasho and Nima have been talking about, that these organizations we're working with in street health here have been doing for years, relying on their expertise and then, trying to meet the needs that they identify. That's kind of where I'm at. And then in my role now, I think it's really more operational, kind of thinking about building the structure so that it fits in with the needs of all of the players involved, getting the voices of the stakeholders, but providing that mentorship and guidance for our students who are really doing so much good work, and are so passionate about it. I think that's really, I think my role is to kind of facilitate those things and then along with Dr. Dasho, kind of navigating the institutional hurdles. So, I mean, I would say that if you're looking to build a program, if you're not involved in an institution where there is one already, um, my takeaway is like you don't have to, it doesn't have to be a faculty member who does street health or who has clinical expertise in that area, um, but one who is knowledgeable in navigating relationships with organizations and institutional kind of paperwork and bureaucracy. That would be the my takeaway from my experience over the last year and a half here.
Cool. Thank you all for that. That's a great way to segue into our discussion. One of the things, I understand, this is a new thing for UT Health, and yet both Doctors Manlick and Dasho, y'all have a lot of experience with setting up clinics, but street health is a little bit different, and I'm just wondering if, first of all, you could like elaborate on what has kind of been different. What are the unique quirks of this compared to maybe other student-run free clinics that you've worked to set up?
I'll take an initial stab, Nandini. I think one of the main challenges, and is these are not bricks and mortar practices, right? So most of the time, like let's say you're a student and you want to go rotate from San Antonio to Austin. There's an agreement, very easy. You go and do a scope of work, you come back. It's very straightforward. Let's take it a step further in that, there's a partner who would like, as part of the relationship with the university, is to be able to host a clinic for their clients. Well, most university or academic health science centers, they are not all, especially in states that don't have or that still struggle with populations that don't have adequate healthcare access. There's not a way to like make a free clinic, right? In a lot of academic health science centers. So usually the partnership is with a nonprofit organization that wants to host a clinic. And so the partnership, is with an organization that has a space. So that has, for example, let's say it's a church, or in some of our cases, it's a church, or it's a nonprofit that has a building that they set up a space for a free clinic for some of their clients. And that's kind of how a lot of these student faculty collaborative practices work. When you're dealing with care on the streets, as many of you know, there's not bricks and mortar. So where is the practice set up, and so for me, I think it's been the adventure has been finding the partnerships who are doing the work and under whose kind of guidance and under whose collaboration we can sort of integrate students into the outreach and use the power of the academic institution to strengthen their work. So, for example, in the case, and Dr. Mondlik will talk probably more about this, but in our case, it has to be a very clear compact between what the university's sort of risk tolerance is and what the nonprofit partner's risk tolerance is. So you have to have that clearly spelled out. There have to be very clear agreements about what a student is going to do and what the faculty are going to do and what our responsibilities are and what our scope is. And that it's clear that these are services that are being provided to the partner to support their work. That comes into play in our case with the electronic health record, which is, part of our university's faculty group practice. Doesn't mean that the faculty group practice has now decided that there's a street program. What they're doing is offering sort of the service of the student faculty clinic as a partnership to the organization that we work with. So for me, the hard part is like not working with bricks and mortar, and sort of handling how we're going to make sure, A, that we are responding to the needs of the population in need, B, that we're responding to the needs of the partner, and C, that we're not introducing students into like what is a very very complicated space without like clear guidance on what your roles and responsibilities are. Because it can, as you know, Nima, and as we've, I brought you in pretty early to those conversations, so you could see that like there was a lot of like we were in like not even in diapers, we were pre-diapers, we were still embryonic, and in the conversations about like how is this going to work, because there's the tendency, because you guys are on a tight time frame, you have 4 years to finish everything, right? um, there's like we got to get out there and start doing stuff, but it's like actually we need to like do it in this way so that we sustain it for groups to come, right? So anyway, I think I've spoken enough about challenges that I found that are unique to street health, but main thing is like figuring out the right partnerships, making sure that we're adding value, and being very kind of clear and circumscribed about what we can and can't do. And then providing the guidance that you guys need to do the right work.
Yeah, absolutely. Thank you for the pediatric reference there, by the way. That was awesome. The embryos. I think yes, all of the above from a kind of regulatory structural standpoint. And then when you get on the ground, like the nitty-gritty part of it, um, because our students are so motivated to just get out there and do the work, and our partners are ready to receive them in that way, my thought process really has to break down into kind of workflows, right? And so thinking through how is this different from a brick and mortar free clinic? And what Dr. Dasho was describing is the model of our other clinics where we have a community partner space, whether it's a church or an existing clinic that operates, during business hours, and then opens up because our partners allow us to use that space for free, opens up after hours to serve a population that we, care for really only in that space because they are uninsured or otherwise vulnerable, can't access care elsewhere. And so so a lot of the workflow logistics are already addressed, right? There's like simple things. There's a waiting room, there's a check-in desk, there's if you're thinking about clinical care, right? There's a place for the patient to be vitalized by our nursing students. Um, there's a private space for the provider and the patient, or the student and the patient, to interact. There's a way to document all of these things, whether electronic health record on a laptop or what have you. There are supplies that are stocked in a closet, that's like around the corner. And then, when the interaction is done, medications are prescribed through the electronic health record, or like a paper prescription is handed to the patient, or we carry the medications in the clinic and they're like physically given to the patient. If there are meds involved, if there are labs or something else that need to be done, there's a different workflow for that, right? All of that becomes a part of the patient record. And then, if you keep walking with that patient, then there's like a checkout process, right? Of what's their follow-up plan? What are they going to do when they come back next time, et cetera. You have contact information for the patient to call them when you get lab results, that kind of thing. When you're doing street health, it definitely has stretched my brain a little bit to think about like, okay, we still need to accomplish these things because we want to provide a high level of care. Our street medicine San Antonio colleagues have been doing that kind of care for a long time in a different way. And so, how can we kind of streamline or adapt to what their workflows are? The place that they were documenting in their record, like how do we get them on board with our record, to unify and consolidate it? And there are a lot of reasons to do that are good reasons, even though it's hard at first to, accomplish it. Um, how do we get these physicians and social workers, case managers who have been doing this work already, like kind of brought into the fold of the institution? Dr. Dasher mentioned like this adjuncting process, like we're not going to be able to pay them anything because we don't have any money. And so we're not employing them, but we do need to put them on paper somewhere because they're supervising our students and they're using our health record. And really, to get access to the health record, they have to somehow go through a vetting process, right? And so, so then with our community partners, like how do we set up communication systems with them so that they can communicate with the people on the ground, with the other partner organizations, with the students more consistently? Is that a secure space that they're communicating within? Like it's not just straight text messages or WhatsApps or something, Slack channels, that kind of stuff. Like it has to be something that's within our system that's secure for patient information, but also sustainable, something that is from year to year. And this is the next thinking process for me is our students are moving through their education, and if we're in our free clinics really do rely heavily on the students as the workforce, getting them oriented and trained at the start of that year doesn't just happen all at once, right? And they're also trying to be students and have a workload and pass their exams. And so fitting into that schedule, but then getting them oriented, trained up, functional, so that they can support the patients and the partners and the physicians, the clinicians supervising them. And then to be honest, then it's like, wow, the year's over and now they're moving on and we have like a new batch of students already, which we do right now. This is January and this is when we start. And so, how do we get that process to become like its own self-sustaining process, but to where it's still effective and manageable by the students on their schedule and also accessible for volunteers. The logistics of timing, I think Nima can speak to better than I. How do we normally our free clinic programs operate, like I said, after hours, because we're using partner spaces that, function in other ways in the daytime. Um, but that's also when our students and our volunteer faculty and students have time, right? Because they have other daytime obligations. And so with street health, nighttime is not the right time to be doing care. And so how do we fit this in so that faculty and students actually have availability to get out there and do their good work? So I think, all of those things put together, there's probably more, but thinking about like a patient going through that process has been for me like the helpful way to bring all those pieces together. And that's where the operations manual that Nima referenced in his slides comes in, of having our students really help them think through that process as well and all the components needed. It helps you really appreciate in your professions, in your future careers, all the things that exist in the background while you're trying to do patient care. Recognizing that all those things, everything is important in there, but we have to think about it in order to make it, manifest. I'll stop talking
And
there.
I know Eduardo may want to jump in too, but I'll
I was
just
going to say we
I see
should hear from Suzanne and Eduardo too. Yeah.
Dr. Egan has a question too. I just wanted to say, like Nandini said and alluded to, like universities are notoriously risk averse, and students are a prized, not possession, but a prized part of the university. And so putting you into spaces that could potentially carry risk is also something that we have to consider as a program. And there are uncertain conditions that exist when you're doing street health. And so these are all things that often also have to be contemplated. Eduardo, I didn't know if you had a thought on Nima's question, and then I see Dr. Egan has a hand up.
Well, what, with regard to like the operations, and everything that it takes to do what BARC does, I think Susan is probably going to be the best person. I can give you like a few pointers with regard to like liability, which you mentioned about academic institutions being risk averse, but actually it was Nima that kind of pointed out that there was a law, of course, dealing with this. And, one of the things that I'm, in reading the law about liability for volunteer health providers, they have to be licensed and work under the auspices of a nonprofit charitable organization, a 501(c)(3). And so medical students are not licensed. And so there has to be a different avenue for them. They have to be supervised by a licensed professional. Is in essence what needs to be done, because, and of course, like a nonprofit like BARC wants to have like good insurance policies, and even with like a licensed medical professional who's volunteering, there has to be a waiver with certain things that are acknowledged by the patient in each case. So and other than, I mean, those are the requirements, because the law does provide a shield. If you're a volunteer, licensed and working for a nonprofit, you're shielded from liability in case death or some other serious harm comes to the patient.
I was just going to say also, this is in Texas, because there might be people in this call from other states. That is the law in Texas. Your state law might be different, but that's where we are. And Dr.
That's a great point. And I just real quick, you reminded me, Eduardo, the malpractice coverage question. That is something that we've had to take into consideration for our faculty as well.
And I should say, I am not giving legal advice. I'm just giving you pointers. I think if you're going to do something like this, you need to consult with a nonprofit attorney or an attorney that's knowledgeable about health law.
Question from the audience?
Yeah, so hi guys, I'm Dr. Eddie Egan. I'm an emergency doctor and street physician, and now as of January 1st, medical director of a street medicine program in New Jersey. We got fully funded through state grants and through some private grants, because you can't just have one stream of funding. And so this is exciting, but obviously there's so many questions that I'm going to have as we go through this. So I've got kind of like a unicorn situation where I've just been nagging people for 2 years, and then finally they said, yeah, let's do this program. How are you? I'd seen on one of the slides of you're like 0.2 full-time employee, 0.2, adding together to have like a full-time employee. How are you utilizing these individuals that already have other jobs and already have full-time clinical positions to then come on your team? Are you helping? I'll let you explain. You both look like you have ideas.
Yeah, I'll because I was part of writing the grants where we bought pieces of people. So part of the problem is that health professionals are not cheap. Mm-hmm. So there's the basic, which we don't have a program where we can afford full FTEs where we can fully fund people. We can buy little pieces, and we were somewhat intentional about who we kind of picked to be able to like buy time. So he's an emergency practitioner. He's been working with the students on the wound care outreach and has recently sort of aligned with the street medicine group. The Street Medicine San Antonio group is its own 501(c)(3) nonprofit. So they operate under their own nonprofit, and on their own volition sort of opted. They didn't want to like necessarily take salary time. They wanted to sign. They're mostly emergency docs and people who work on shifts. So they wanted to be able to sign. They wanted to have sort of a pot of funds where they could sign up for shifts. So their money works even more differently than ours, because they sort of got a sub-award and then they apportioned pieces for shift time. So to sign up for like a 4-hour or a 5-hour shift and get a certain compensation per hour for that. On the faculty side, I built a little scotch of my time into a couple of the grants, just to kind of like justify that I was doing a lot of work coordinating it, especially for the student part. The one that we've been able to support actual faculty FTE was our state grant. And it's a 2-year grant, so we're already looking for where that's going to come from in the future. We picked one guy who's in the ER, and then we actually we had to bring this other practitioner who's an addiction medicine certified EM doc who does work with street medicine on in their role to kind of supervise the residency training part. So it's even this is why it's such a crazy coalition, is because there is no like one person, like there is no Eddie Egan at the head of it who's sort of putting the pieces together. I think it's easier to work with EM because you guys do work on shifts. So you essentially say, well, if I'm paying 0.2 your salary, that's going to reduce your number of required shifts by this amount. So they're still going to do, let's say instead of doing 12 shifts a month, they're going to do 9. And, the rest of the time is dedicated for street medicine work. So that's how we've worked it out with EM colleagues. With internists, it's much harder because you're now talking about either hospital weeks or shifts, or primary care days, and that's even more complicated. So the ideal, and then to say nothing of our nursing colleagues who we also pay a piece of, and all of this is really in their role in the educational space. So we're not even supporting them for clinical work because it's non-billable. The way the institution sees clinical time is you've got to be able to bill for it. So right now we have no infrastructure to bill for street outreach work. So all the funded FTE is educational. It's under grants, but it's funded for the education. So I don't know if that answers your question, but it's sort of having very clear expectations with the faculty on like what am I getting with that 0.2? We're making sure you're going to show up to every coordination meeting, that you're mentoring the students, that you're, but it's still a work in progress. So I don't know if that answered your question, and I don't know if you have anything to add on your end, Nandini, because you have a sort of a different arrangement as far as the free clinic role. But in terms of the street outreach, I'll just say that for EM, we set it up as shifts that they could sign up for and sort of extract from a pot of money. And then for the more director educational leads, we put them with like dedicated FTE instead of sort of signing up for shifts.
Okay, well, that's smart, and because I think, trying to how do you hire someone for a half-time position when they're already hired full-time by the hospital? It only really works if the person's already per diem or part-time, ideally like from the emergency department where they're just picking up shifts. So that is kind of.
And the question I'd have for you, Eddie, is the hospital like,
Right.
Is it the hospital's street med program, or is this sort of a nonprofit that exists outside of the institution?
This is I'm working from the Department of Emergency Medicine for my hospital, part of the monstrous organization of the state of New Jersey, basically. So it's all Robert Wood Johnson. So they have 20 hospitals, and this is the first iteration of it. And we're just trying to make things work. I looked at a van today. So so we got big things coming.
That's
but
good.
Beyond to me is going to be challenging.
I think what I would add is only that, to think about, you sort of need a critical mass of individuals, right? Because even if you were going to hire half a person, they could get sick, go on vacation, whatever. And so you really need to, like, just from our free clinic standpoints in general, have kind of a pool of people that you will be able to draw from. Whether they're there, every week or not is totally how you structure it. But it may be a mix of people who you're paying and people who are volunteering. And so to think about numbers of like, what time, like how many hours are you trying to actually cover in your population's needs? And then start with that and then go from there of like, okay, like reasonably, how many people do I need to be able to do this? We don't want to burn anyone out, but we also need to build rapport and trust with our leadership to be supportive of buying someone's time out. Because if you buy out an emergency medicine physician's time, like take 2 shifts a month, because you're paying the institution for that salary, that's cool, but somebody still has to cover the ER,
Yeah.
right? So like there's this push and pull, and I think that's something you really have to think about when you're considering like how many people you want to get um, in this core group. And then, start small is what my suggestion is, and build from there. That's kind of how most of our programs have been successful. Yeah. And then be ready to flex it when you need to.
Yeah. Awesome. Thank you guys.
Yeah. Good
Sorry
luck.
to
And for
interrupt.
sure, reach out if you need to.
I will reach out directly to you guys
Yes.
too.
Yes.
And I would look, Eddie, at I was just pulling it up. I mean, there's so many programs now, but one of the ones here in Texas that we've sort of looked to, at least for like kind of how they've operationalized things in our sort of unique, state and situation, is at JPS, so John Peter Smith. It's in Fort Worth, and they have a street medicine fellowship. They have a great partnership with the academic hospital.
Actually, I texted Joel today too, so he's on my list of people to
Beautiful.
ask a lot of questions too.
Real quick, because I know we're gonna have to stop here in just a few minutes. I just really want to quickly throw out one question on behalf of the students. What is for a student who's really passionate about starting a program like this at their school, but there's a lot of work that needs to be done. How do they advocate for this? How do you approach administration? Do you have suggestions on how to communicate with people? Do you have any, big don'ts? Anybody in an administration to work on? You mentioned, Dr. Dashwell, becoming sort of cynical. I'm just wondering if you can speak to that a little bit and just more broadly about advocating for something that you believe in as a medical student when you hit roadblocks.
No, I mean, I think the key is, I think we've been very fortunate here because I think our leadership understands that we are in a very in need part of Texas. We're in South Texas. We're the seventh largest city in the United States. We have a very we have a huge veteran population here. We have a lot of people experiencing homelessness. And so they understand that I think part of cultivating compassionate healers for the future is creating opportunities for you to serve the community. And so I think when people are running into roadblocks, I always approach it this way I've approached it this way in my entire career with global work. Most people aren't, with some exceptions, aren't introducing roadblocks to be difficult. They're because these are like actual sort of like policies or things that exist for a particular reason. And it may not be a reason that's relevant to what you want to do, but if you find a great, good advocates in your legal office or in your senior administration that can help you navigate them, it's not a way to bypass them. It's to say, they want to see that this is being looked after. When we were going through all of the back and forths with Eduardo and with BARC on getting our agreements set up, it was like, here's what BARC's interests are, here's what the university's interests are, here's what we're comfortable for, and for terms of language, and you're able to overcome it, right? That you could just get tired and stop at the MOU. So I would say, like, have allies and just look at those barriers. It's hard because they can feel very frustrating, but people want to see you guys succeed in doing good work in the community. I think what they don't like things that are going to potentially expose them to lawsuits, expose you to risk, expose patients to risk, have students doing things that are outside of their scope, be potentially, exposed to other liabilities. And so as long as you respect that is part of their job, I think the conversation can be very productive. So I've had to learn that over a long period of time because it was not always my approach. I used to come just like a bull in a china shop and tried to like just disrupt and the problem is that like you'll come and you'll go and those rules will still be there. So the best is always to say, what do I need to do? How do I do it? What do you recommend? How would you like me to phrase this, et cetera? And then, form your partnerships. yeah, and form your coalitions, and people will get behind you. I have lots of other thoughts, but I'll let maybe Nandini and Eduardo share answers to that.
Yeah, just I think my approach has always been eat the monster from the inside. So I think, working within the constraints that exist, we end up more successful than kind of beating our heads on the wall. But lead with curiosity, I think is true for as the life lesson in any situation where you're feeling frustrated. Um, Definitely understand what the intention is behind whatever pushback that you're feeling. Sometimes we have students wanting to initiate things which are services already provided in the community. And so, in the effort to not be duplicative, to be sustainable as an intervention, thinking about the bigger picture beyond like your studenthood, right? If you're trying to actually make impact in your community, that's what I would suggest is like to think about it, take two steps back and think about it from that way. Um, Wonder about why you're getting whatever feedback that you're getting, and then have faculty members who you can seek guidance from easily, like where they're willing to just talk things through and just be real, who are, steadily there with you, can make a big difference because they will understand how to eat that monster.
Thank you. And I see we have a question.
Hi, yeah. Thanks so much for doing this. This is really great. I'm a student at Mount Sinai in East Harlem in New York, and there's a group of us that are just kind of what you described, just getting our feet wet and looking at what starting a street outreach team would look like here. We've come up against a lot of like the administrative obstacles already, and I wanted to get your opinion on how effective or necessary like a formal needs assessment of the community is. We have evidence from like similar communities at the effectiveness of street outreach, but that was kind of like an avenue that we were looking into, and I wanted to know if there's experience with other schools and maybe like what contacts would be good for conducting a needs assessment.
So I will say that, like, as part of our CEL program, we like needs assessment is part of it. But remember that needs assessment doesn't necessarily mean primary data collection. Like, needs assessment can be a review of available literature. It can be somewhat unethical to actually to enter a community where there's already been a question answered and then try to now answer it again for yourself, right? So I think the first question I would have is like, what form does the need assessment need to take? New York is, I mean, if you look at what the publication, if you look at do a PubMed search for like street medicine programs, like you're looking at mostly bi-coastal programs in San Francisco, LA, and then New York, New Jersey, et cetera, that have like been publishing and been doing these programs. So I think, I would say you might be able to get away with, let's say, key informant interviews from existing street medicine programs in New York. Like Albert Einstein has a really robust street medicine program. I had a former student that did medicine. I think she was I don't know if she did at Sinai or at NYU, but then she went on and did a street medicine fellowship. At least at the time they had it. I think it was through Albert Einstein. And so I would say you have lots of programs. We had sort of a coalition of nonprofits here, but you have like lots of, street outreach programs that I think you could lean on to. Most of the time, if your administration is asking for a needs assessment, or it's to sort of, it's part of the like best practices of community engaged learning is to clearly articulate what a community's need is and to learn how to do that. But I think where I might get guidance from those in your institution is like, what form does that need assessment need to take? Do I need to go out and do surveys or do my own, is this a do your own research, or is it, can I do something where I'm working with existing data, existing publications, and then organizations that are doing the work to like kind of like come up with what our contribution might be? How are we contributing? And really, how are we benefiting, right? I mean, you have the benefit of being in a big city with a lot of programs. So, your contribution may be more, we're going to bring more energy, potential more donors or funding or whatever. What's our value add? So I don't know if you wanted to add anything to that, Nandini.
No, that's exactly. I was just going to say what you need to identify is what's the gap that you're filling. And that's how you're going to convince your leadership that something more needs to be done because it's us educating them if they're not already aware of what does exist. They may just go like do a Google search and go like, oh yeah, there's all this stuff going on already, right? Why do you need to do something more? I don't have money for that. I don't have time for this, you know? And so it's sort of like speaking that language, um, recognizing that they may need some education. It's an opportunity, right? Turn that glass upside down. So I think, but just think about like what niche, what specific area are you trying to fill, especially in a place that has a lot of existing services.
Yeah, thank you so much. That's really helpful. And yeah, there's lots of programs. Somehow we're kind of in a neighborhood where we're at somewhat of a gap very randomly, with a big population need. So I do think that niche exists, but that's really good advice to kind of look at already existing programs and see what data they have. So thank you.
Yeah, I think don't lose hope. I mean, it's very inspirational to have so many students that are wanting to be a part of this coalition from all over the country. I think it doesn't go unnoticed by your faculty. They may not always say it, but like I think having folks like yourselves who are really committed to compassion and to serving the community, this is a muscle you get to build and then bring into your career. This is part of the like evidence base that exists. You can't sit in a classroom and learn compassion. You have to go out and experience it. And yeah, I did street rounds this morning with some of our colleagues, and the more stories I heard, the more like I felt, connected with what I was doing, right? And you guys, you want to have that experience too, and that's like, I think most of your administrators, the warmth of compassion is gonna melt the coldest hearts of an administrator. Okay, like most administrators are just like looking out for you. They're trying to do their job, and nobody's, I think, trying to like really stand in the way. But we are also like Nima knows, we've talked about it a lot. Like we're also looking at sustainability. What's the downstream? What is this going to like when we take on a program? We're committing, right? We're not just going to do a flash in the pan, do a program and then leave, right? So you'll be here 4 years. We're going to be here for 100. And so like, what's the how is this going to be sustained? It's often something that people are thinking about. So again, like it's framing those things, like the needs assessment is maybe the first step to being able to achieve that.
Nima, I thought in answer to your question about like advocacy by students, one of the things I saw you do is you developed relationships with people at Corazon Ministries, people at Bark, and I mean, those relationships are really important. I mean, you learned what these organizations were doing, and I think you were able to serve as a liaison for these organizations with the institutional players at your academic institution. So I think that really helps in advocating, is having those relationships established.
I will just say from my own experience, it does help sometimes to have like I think sometimes big institutions like just the leadership talk to each other when there is like a partnership in place, which helps, of course, but you also want to see the people who are claiming that they're going to do the work actually showing up, right? Because then otherwise it just seems like kind of what Dr. Dasho said is like, how's it going to be sustainable? We have this program here, but nobody's filling in the role. It's like, it would almost seem like the admin is just doing something for you instead of, you doing something for them or for the partner, and like making sure that you're, like Dr. Dasher said, adding value.
And Leah, do you have a faculty champion, like someone who's kind of sort of taking it on and saying, I want to support you guys in this?
Yeah, we've actually had quite a few faculty members that we've talked to be interested. We have a free clinic as well, and the main faculty of the free clinic is definitely with us. So we've been very successful there, which is great.
So I think if that's all the questions, we can end it here for today. But thank you to everyone that came to this webinar, and also to the panelists that were able to provide so much information for all the questions and just on how to start a street medicine program. So thank you so much for like taking time out of your day today and like um, giving us that information. And yeah, this is like their contact info. Um, and the sign-in form is in the chat. And I will also send an email to all the people that registered with like this information and also the sign-in form. Um, but yeah, if you have any questions, you can email us or also the emails here on the shared screen. And yeah, good evening, everyone. And thank you for joining us today.
Yeah, feel free to reach out to me at any time. I'm like the incoming team development specialist. I just try to share lessons that I've learned or that I've learned from other students at other schools with students who are interested in starting these programs. Thank you all. Thank you to the panelists so much. It's a great talk.
Thanks, Nima. Thanks for inviting us, everybody. Keep up the good work.
Thank you, everyone. Thank you for being here.
Thank you, guys. You were great.